Good afternoon, everyone. This is our resurrected session for the GN Talks. Today, we will talk about lupus nephritis. I love the title, as Dr. Aga put it on, Taming the Wolf. Yeah, lupus sometimes is cheetah, sometimes is wolf, but I like the way he chose the title. It is a wolf. It's very smart. It's very active. It can go different traits of the wolf. So let's see what Dr. Aga has to present. So I have Dr. Abbas Masood join me as panel and all our lovely, wonderful guests as well. So thank you for joining. So without further ado, over to you, Dr. Aga.
Thank you, Mark. Yeah, I mean, it's just a play on the fact that lupus in Latin is wolf. So that's where the name comes from. Thank you everybody for joining. So I'm going to change the format on this just a little bit. Lupus is a huge topic. We could maybe do 10 talks just on various aspects. So I'm going to try to walk us through management from a practical standpoint and see how that goes. So we all understand how lupus works. I'm not going to go into the details of this pathophysiology, but due to failures of autoregulation at many different steps, you develop antibodies against antigen. So if you imagine the myeloid cells die in the circulation every day, their DNA and cell-free DNA is released into the circulation as soon as those cells are dying or undergoing necrosis. That DNA is swept away from the circulation very, very quickly to avoid any immune surveillance. But if there is any defect in immune surveillance and those DNA type materials are not removed from the circulation in time, then the innate immune system is able to pick them up and process them as antigens of interest. And if there's any failure, so that's another set of failures in curbing down autoreactive T cell and B cell clones, then those antigens would elicit an immune response. So your ANA, anti-DS, DNA, and all the others, SSAs, SSBs, etc., are autoantibodies that are generated against nuclear material due to this failure of regulation at various steps. And then certain types of antibodies can then make antigen-antibody complexes deposit in various tissues. These are usually capillary-rich tissues, so your synovial membranes and glomerulus. And so you get arthralgias, arthritis, you get kidney damage. They can settle in the pulmonary capillaries, leading to pulmonary vascular issues, etc., etc. And so when that happens, you get organ damage related to SLE. Now, we are involved with the kidneys, so the involvement in the kidneys can be in any part of the filtration unit. The mesangium is almost always affected because these antibodies, if they're making circulating antigen antibody complexes, or if they're going to make an in situ antigen antibody complex to an antigen located inside the mesangium, this is where the antibodies kind of seep into the mesangium. And so this is where you see the first activity. And so you cannot have lupus nephritis, even lupus podocytopathy, without having some activity in the mesangium. And then you can get what we used to call proliferative disease. We now call it hypercellular disease because there's nothing really proliferating here. And then you can get the membranous version. And we'll come back and look at these histopathologic classes in a little bit. But suffice it to say that about 50% of the patients who are going to develop SLE are going to develop lupus nephritis at some point. And usually, if a patient is going to develop lupus nephritis, that happens within the first 3, 4, 5 years. Within that period of time frame, 90% of people have actually manifested their lupus nephritis after the onset of lupus in about 5 years. Now, it is not a benign disease, So this is an old study, but I always put it in there to just elaborate a few points. So there was a big trial that was done in the early 1980s. Ed Lewis at Rush conducted that. The question they were trying to ask was, is plasmapheresis helpful in lupus nephritis or not? So this is the early 1980s. They had about 86 patients. They randomized about half of them to standard of care, which at that time was prednisone and cyclophosphamide. And then the other half, they put them on standard of care plus plasmapheresis for a couple of months. So the answer to that question was it didn't make a difference. But then the Rush people, a couple of decades later, went back and looked at that cohort. And what they found was that if you received therapy and you underwent complete remission, right, your survival was significantly improved. So this says both survival. One of them is kidney survival, one of them is patient survival. And so your survival was much improved. If you had no remission at all, didn't have any response, you dropped like a rock. So at 10 years, the mortality was in excess of 50% in these patients. This is patient mortality, not renal outcomes. And if you had partial remission, you were in the middle somewhere. So this is not a benign disease. This affects young people. So, I sometimes hear many colleagues saying that, oh, membranous is benign. It only affects 10%, it only commands a 10% ESRD rate at 10 years. But is 10% acceptable for a 25-year-old? That's a very, very high risk of end-stage renal disease in 10 years. So this is by no means a benign disease. And we all understand that it is not just the renal outcomes that derive this. When they develop CKD, the cardiovascular mortality and morbidity really skyrockets as well. So treating this disease aggressively, treating this disease appropriately, and deploying a holistic, multidimensional approach to not only protect the kidneys and affect and command good renal outcomes is important, but also affecting good cardiovascular outcomes is essential as well. So this is what the problem looks like. Now, let's take a look at Sandra. Sandra is a hypothetical patient. I just made it up this morning, so this is not a real patient. So, a 25 years old female, joint pains, arthritis, rash on her face, and that started a week after a trip to Disneyland. This is very, very typical. You go out in the sun, you have damage because of ultraviolet rays, your DNA material is picked up. Remember, it's not being swept away from the circulation by the DNA ligases as it should be. And so it is then communicated to B cells, to memory B cells, and within 3, 4, 5 days, there's sheets of plasma cells that lay out more antibody, and you have a flare. So that's, or a presentation. That's how it works. So our ANA is 1 to 120, dsDNA is high, C3 is low, urine has red blood cells and protein, and the protein creatinine ratio without any therapy is 800 milligram per gram. Her GFR is maintained at 110 mLs per minute. So her renal function is normal. She's got about 800 milligrams of protein in the urine. She does have blood cells and protein in the urinalysis on the dipstick. Our serology is up there. So, I'll invite my panelists here. Omar, Avas, how would you approach this patient?
I mean, first of all, let me express truth. First of all, I mean, I have a she should be on, that medication which are normally maintained for SLE patient, but at the same time, I have very low threshold to do biopsy on these patients. Okay, even sometimes very, she has significant proteinuria. She has active lupus going on with the low complements and everything goes. So she has renal involvement with the shows with, then that's first thing I would do, that I will make sure that she get a renal biopsy, and she might need it down the road. Multiple renal biopsy depends upon her progress and condition, and respond to the treatment if she needs any. So that's first I would do.
Very cool.
But at the same time, she's on, I mean, all the other medication which are needs for, like hydroxychloroquine, all that medication. But obviously, before we think about starting an immunosuppressant therapy, we need to have a kidney biopsy.
Very good. Omar, any comments from you?
Yeah, same response. I think two decisions which we need to make if this is a Friday afternoon or Thursday afternoon, that like you have to wait the biopsy on Monday. One question is like, with this GFR and this degree of proteinuria, does he need something? Or we just do the biopsy. I think biopsy is the must, and that's what, before the session starts, we were discussing as the importance of biopsy and rebiopsy in these patients. So when you are dealing with lupus, please have a low threshold to do biopsy. So on principle down, biopsy is the first important stuff. But if tomorrow her GFR drops, or I see some other thing, I wouldn't hesitate while waiting for the biopsy on Monday morning to treat her.
Very good. So let me just, as a hypothetical situation, propose that, you arrange for a biopsy in a week's time, and you put them on an ACE inhibitor, and the proteinuria drops from 800 milligram per gram to 400 milligram per gram. So it's now less than 500 milligram. The GFR is maintained. Would you still biopsy the patient?
My answer is yes, Dr. Masood. What do you think?
I would do that, yes.
So I think you're exactly right. And KDIGO in their 2024 iteration agree with that. Now, 500 is a number, right? It's just a line drawn. And when Avas and I were in our fellowships, this line was somewhere between a gram and a gram and a half. Sometimes some people would say 2 grams. But that was a different era. We have now learned a couple of things, and I will keep reiterating these as we speak, as we go through this presentation today. Early diagnosis of lupus is extremely important. Every flare of lupus, every presentation of lupus nephritis, and when I say lupus, I'm going to use lupus for lupus nephritis. We are only talking about lupus nephritis. We're not talking about generic SLE. So sometimes I just say lupus. What I mean is lupus nephritis. So every episode of lupus nephritis, every flare of lupus nephritis damages the kidney. And if you accumulate enough damage, you will then develop chronic kidney disease and the risks attended by the chronic kidney disease syndrome. The mortality, morbidity associated with cardiovascular outputs starts going up as you accumulate kidney damage. So mostly when people are in this stage, they've come in with a diagnosis of lupus and they're developing some proteinuria, they're still with their rheumatologist because they feel comfortable messing around with this as long as the kidney function is stable. It becomes more challenging for them when the GFR starts dropping. So it is not unusual for me to see somebody with SLE whose GFR is in the 60s or in the 50s. Now imagine this 25-year-old female. By that time, she's already lost half of her GFR. I mean, she's not on the CKD3 radar for us, which is our paradigm for diabetic kidney disease or other non-active progressive kidney disease. But for this inflammatory disorder, you've already lost half of the GFR. Now, just to kind of pick up on what Umar was saying, this is Friday afternoon. Would you pulse this patient? So would you bring her to the hospital and give her a steroid pulse?
I think the patient you mentioned, so...
Yeah, we're talking about Sandra with a proteinuria of 800 milligram, GFR is maintained, and she's got rash and arthralgias, arthritis, and she's got, some blood and protein on the urinalysis.
So gray zone decision. So probably not for Sandra, but if some of the parameters, and then I think the parameters are hematuria, proteinuria, and GFR here. And of course, you mentioned the dsDNA titer and the complements. If they are either very severe or worsening, I have a low threshold. If this is a Friday, if I'm very convinced that this is lupus, nothing else, this is a young patient, time is nephron here, I have a low threshold to also pulse them over the weekend. And again, I think this is a debate. This is something that we can discuss and maybe learn from the experts today, as like what is KDIGO saying and what the approach is. But I have a low threshold to treat on
Yeah,
Friday afternoon.
yeah, I agree. I mean, patient definitely needs steroids, no question about that. Even waiting for biopsy to be scheduled, whether need a pulse or not, that's debatable. But I don't think anything to lose to give a pulse. Also, this patient has active lupus nephritis going on. So, sooner you stop the process of, I mean, what could damage your kidneys, I mean, it's better.
So let me just be a little more provocative here, and I'm maybe jumping the gun, but since this discussion is moving in that direction, do you worry that you're going to change the histopathology and your ability to interpret that by pulsing and waiting a week for the biopsy? Let's suppose the biopsy can be done in about a week's time.
I mean, I don't think that will be a significant change in our biopsy with giving pulse. I mean, if there is changes in the glomeruli, or I don't think that they will change just giving a pulse within a week. I mean, why? For the other thing that I would not do, I mean, wait for a biopsy for a week. I mean, things happen. Sometimes patient use outpatient, they cannot be admitted right away. Biopsy cannot schedule, but I'll do my best to schedule biopsy as soon as possible. But in that scenario that it would take a week, I still will not be worried about that. I will not have a diagnostic tissue at that time. I mean, I will not hold back if I decided that patient needs a pulse.
So, there've been studies on this, and essentially, when you give somebody a steroid pulse, the first thing to melt away are crescents, and they can melt away in days to weeks. Your neutrophil infiltration of the glomerulus gets better pretty quickly as well, but other things, other types of endocapillary proliferation, and obviously the chronic changes, they take a long, long time to go away. So there's some change in histopathology, but not much. But here's how I would treat this patient. This patient is stable. Their GFR is stable. Yes, they've got inflammation going on, but 2 days or 3 days more or less of this is not going to change the overall arc. The question is to get on top of this. So if they're in the hospital for any other reason, that's fine. But if they're as an outpatient at this time, I'll put them on oral steroids in a good dose. I'll put them on other therapy, hydroxychloroquine, whatever you want to do. But I will try to get a biopsy done as quickly as possible. Now, if this was somebody whose GFR was dropping, I would probably think differently, because then you're almost looking at it as an RPGN type syndrome, in which case you will probably put them in the hospital, do a steroid pulse, and then take it from there. Now, many of these patients, we don't have a lot of experience seeing them, because we see them when they already are dropping their GFR. So that's what informs our decision making. These are the patients that rheumatologists see in their office. They have gone to the primary care doctor. The primary care doctor looks at them, says, yeah, maybe you got lupus, you got this rash, and you got protein and blood in your urine. Sometimes the protein and blood is not even picked up by the rheumatologist for a month or so. They're still messing around with hydroxychloroquine and oral steroids and belimumab and this and that. And then somebody says, well, they've got protein in the urine as well, or the GFR number moves, and then they send them to a nephrologist. So yeah, I mean, I understand completely the impetus that we need to get on top of this quickly. But if you're starting them on oral steroids and arranging a biopsy within a few days, I don't think that's unreasonable, because putting them in the hospital for a steroid pulse blind without histopathology might be a little bit of an overkill there. But yeah, the underlying um, let me just make one more point before I go for the underlying principle here is they need therapy quickly, they need a biopsy quickly, There's an arbitrary line at 500 milligram per gram, but what if this patient's proteinuria was 400 milligram per gram? So now I'm going to throw this back to Avas and to Umar. I'm just trying to be a little provocative. What if, with all this presentation, Sandra had 300 milligram of protein in the urine by ratio? Would you biopsy then?
I think we
I
can
mean,
repeat the testing tomorrow, or get a 24-hour urine testing for confirmation, because now this is more, I think the situation is subacute, so now we have a little bit time to have this stepwise decision, to have better assessment, more accurate assessment, and then come up with a plan.
Let
But
me
again, going back to Sandra, if we look at her hematological markers, and if there are, if everything is pointing towards lupus nephritis, at some point, proteinuria is just one element of the decision making. That's what I will have a stepwise decision and come up with something.
I'm just trying to play devil's advocate here. So let me kind of tease it out a little bit more. What if on the first test she had 550 milligrams per gram of protein, and the second one she had 450 milligram per gram? Does that change your thinking about it?
I mean, I would do biopsy. I don't know, Dr. Masood, what do you think?
no, I mean, this just a slight difference in the proteinuria will not change my plan on this patient.
So I think that's kind of a question, the answer to which is being addressed right now. There's an NIH mandated project where they are biopsying people with 300 to 500 milligrams of protein to see what happens, and depends on the context, right? So in this person whose diagnosis is really clear, who's got very high levels of markers and systemic consumption of complement, and they've got an active urine, I would look for a reason to biopsy. There's a chance that if they had 300 milligram of protein, I'll just find class 2 lupus. But there's also a chance that I'll find class 3 lupus. And Omar said it right. Proteinuria is one marker. It's not the only marker. And I think sometimes we develop a very proteinuria-centric approach to assessing lupus activity, and we have to look at the patient holistically. So in this particular situation, even if the protein was 300 milligram per gram, I would go ahead and biopsy and see why does this young person has protein and blood in the urine, right? And this is what we get out. Class 1 is nothing. Class 2 is mesangial activity. 3 and 4 are proliferative disease. And there's someday we will get around to looking at the nuances of this biopsy and how archaic this classification is. But this helps us just pigeonhole patients into some box here. So class 1 and class 2, really we don't do much. We let the rheumatology people treat the way they want to. Class 3, 4 is considered aggressive. Class 5 is considered a little less aggressive, but they're all lethal in the long term and do drive significant ESRD rates. Obviously, 4 and 5 can be in combination with 5, in which case the 4s and 5s actually drive the outcomes. Let me just make a couple of points here. We look at these as, fixed diagnoses. If you rebiopsy them, so rebiopsy studies have demonstrated that about 70% of these patients would change their class. So we have to always stay nimble in our mind and consistently reassess the patients. And we now need to have very low thresholds for rebiopsying and reassessing, because unfortunately we don't have good markers. There's activity scores and chronicity scores that are touted, and sometimes people focus on them very, very heavily. They are designed so that the different pathology institutions can talk to each other about what they're talking about. So you need to read the full biopsy report and understand what's going on in the kidney to make a realistic assessment. So I'm not going to go into the details of the pathology more than this, but let's suppose Sandra had class 3 disease. So how would our experts treat this patient? You got Sandra, who's got a new diagnosis of lupus nephritis. She's got class 3 lupus. She's got 800 milligrams of protein in the urine. Her GFR is maintained. So, Avas, how would you treat this patient?
I mean, definitely, if she has class 3 and she has proteinuria, she needs a pulse, and after that, she needs class 3 needs a immunosuppressant therapy also. I mean, I would definitely, she will go for with the steroid. She will go, but like that she needs a double, dual, or she needs a triple therapy. So in class 3, I think definitely mycophenolate with steroid. I will start that on this patient after the pulse therapy.
Very good. So that's a very reasonable way to look at it. Omar, how would you think about it?
Yeah, I think first thing, as Dr. Masood mentioned, so lupus is becoming more or less a 3-drug condition, especially for the 3 and 4 in advanced and active lesions. So the things in the armamentarium or steroids, MMF is very cornerstone in our experience and literature. Voclosporin is one of the option. Belimumab, I mean, when we go into biologicals, there are some other options like belimumab as well. But I think in this case, we can start with, and patient's GFR is preserved. So based on the availability, based on this, I think we can start with steroids plus MMF plus minus third drug.
All right, very good. Okay, so I think what I'm hearing from both of you is that yes, we need to do immunosuppression in this patient, which is absolutely correct. We need to use steroids. Nobody's against that, so everybody would use steroids. I think everybody would pulse with steroids, which is important as well. And we'll kind of go into some of the nuances as the talk progresses. And then everybody agrees that we need to have MMF as our anchor. So people would start MMF, and then we'll see how things go, and then see if something else is required. Have I distilled both of your thoughts correctly?
Yes.
Okay, good. All right, so let's kind of walk through this, and I will challenge some of these assumptions, and I will invite you to think about this disease slightly differently based on the data that we have. All right, so this is, how the therapy of lupus came to a point where our experts left it, right? Essentially, the steroids were started in 1960s. Actually, 1950s was the first time when the first steroids were used for lupus. In the 1960s, they became a little bit more mainstream. Then people started using cyclophosphamide. In 1986, the landmark NIH trial came up, which came out with the NIH protocol where you would use cyclophosphamide monthly for 6 months and then quarterly for maintenance for a couple of years. In 2000, Chan Wan from Taiwan came out. Dr. Chan was the study. This is the first study that did it. It's called Chan Wan in lupus parlance. And so 2000, Chan Wan came out, and it demonstrated that cyclophosphamide induction was equivalent to MMF induction or the other way around. And so that put MMF on the map. In 2002, Lupus Nephritis trial came out, and this looked at a lower dose version of cyclophosphamide because we are really worried about cyclophosphamide toxicity. So what they did was, instead of the full shebang of using cyclophosphamide monthly for 6 months and then quarterly, yada yada, they went on a much smaller dose of cyclophosphamide, which was 500 milligrams every 2 weeks, and a total of 6 doses, so a total exposure of 3 grams. And that was the cyclophosphamide induction part of it. And this was found to be equivalent to high dose cyclophosphamide, with the caveat that it was Euro lupus nephritis trial, so it was in a predominantly North European Caucasian population. But it has since been duplicated in the US as well, and many people use this now instead instead of using the full dose cyclophosphamide. And then the ARMS trial came out towards the end of the first decade of this century, where in a US population, MMF was found equivalent to cyclophosphamide. So the guidelines that came out in 2012 said, okay, we need to use an induction agent for proliferative lupus. Okay, and the steroid induction part of that was methylprednisone. At that time, we were using 500 milligram to a gram every day for 1 to 3 days, and then we would put them on a mg per kg of oral prednisone. So that was your steroid component, and then there were options, and the options were you could do the classic NIH protocol, you could use oral protocol. There are some institutes in the country, when I say the country, in the US, still use oral cyclophosphamide for lupus induction. Ohio State is one of them, which is one of the biggest places where lupus nephritis is treated. And then the low dose intravenous cyclophosphamide arm, which is the Eurolupus protocol, or oral mycophenolate mofetil, 2 to 3 grams per day for 6 months. So this is your induction part of it, right? And so at that time, look at the terminology KDIGO is using. They're using induction, and then there's a maintenance arm, and we'll talk about maintenance later. So they're using as induction and then maintenance therapy sequencing. So in 10 years, so till 2021, not much changed. The only things that changed were a little bit of a simplification and the idea that we're using too much steroid. So we want to use less steroid, and I'll show you why. And so instead of the 500 milligram to a gram per day, the pulse now is 250 milligrams to 500 milligrams based on how heavy your patient is. And then you put, instead of a mg per kg, you can do 0.6 to 1 mg per kg per day of your ideal body weight, not your real body weight. And you can taper pretty quickly. And so in the 2021 version of lupus nephritis guidelines, you wanted to get rid of the steroids down to 7.5 or less. And then obviously, as your immunosuppression anchor, you could use MMF, or you could use the cyclophosphamide Eurolupus protocol dosing schedule. This is where lupus nephritis was in 2021. So if you put somebody on this induction, if you put them on steroids and then you put them on Eurolupus cyclophosphamide, or you put them on MMF in a dose of 2 to 3 grams per day, what is the chance that your patient would be in remission at 1 year? Anybody wants to take a guess on that? At 1 year, what is the chance that your patient would be in remission after starting this therapy? And I was looking at some chats while you guys are thinking about that, and there's some people who are chiming in with their answers. There was a question: is class 3 proliferative? Yes, it is. Class 3 and class 4 are proliferative. Omar, if you would be very, very kind, there's a lot of activity on chat. So if you could just pick up the questions, so at some point we can address them as well. Okay, so I've seen some responses. Somebody said 40%, somebody said 80%. So what I present to you here is the control arms of 3 major trials that have been done recently. So this is in the second half of the first 2 decades of the 21st century. Aurora was the voclosporin trial, Bliss-LN was the belimumab trial, and Nobility was the obinutuzumab trial. So what you see over here are response rates in the control arm. So the control arm in Aurora received steroids and mycophenolate. In Bliss-LN, 25% received cyclophosphamide and 75% received MMF. And in nobility, everybody got steroids and MMF, right? So that's the standard of care that this guideline is dictating. And with that, at week 52, which is about 1 year, in Aurora, there was 23% of patients who were in remission. In Bliss LN, there was about 20% of patients who were in complete renal remission. And in all three trials, the remission that I have put over to have apples and apples is a proteinuria reduction of less than 500 milligram per gram and maintenance of GFR. And so in the obinutuzumab, it says placebo, but it doesn't mean that these guys didn't get anything. These guys got steroids and MMF. In lupus trials, there's no placebo. There's standard of care, and then there is intervention versus placebo. So in Aurora, there was MMF steroids. Everybody got them. And then the intervention arm got voclosporin. The placebo arm got sham. Bliss LN, everybody got steroids and either MMF or cyclophosphamide. And then the intervention arm got belimumab, and the control arm got sham. And likewise in nobility, everybody got steroids and MMF. Control arm got sham. Intervention arm got obinutuzumab. So your response rates with this therapy that we just outlined are between 20 to 30%, which is abysmal, which means you can assume when you're starting therapy that 60 to 70% of your patients will not respond to it. And so what we are exposing them to is continuous damage. So each flare of lupus damages the kidney. And if we are not able to control this inflammation, then the kidney keeps going down and eventually, and eventually we will hit end-stage kidney disease. Now, if you've lost some kidney function and you're able to turn the inflammation off, then you can sustain the kidney function for a much longer period of time and delay onset of end-stage kidney disease. Avoid it if possible, and also you have to mitigate the cardiovascular adverse events that happen with the chronic kidney disease syndrome. So it is very important to get on top of this inflammation as early as possible, as quickly as possible. Now, people make this mental distinction that, oh, this is just class 3, right? This is just class 3. If it were class 4, I would do something differently. But understand, people who were included in this trial, they all had either 3, 4, or 5, or a mixture. So you cannot parse those data. So when you look at these outcomes, these are people who had 3s, 4s, or 5s. In Bliss LN, the average GFR in the control group and in the intervention group was about 100 ml per minute. So these are all people who've got preserved more or less GFR at this time, but then many of them met these endpoints of reduction of GFR or protection of GFR based on your intervention. So it is very hard to parse. So if you've got an inflammatory disease in the kidney, you need to shut that inflammation off and give your patient the best possible chance. Now, the second lesson that we have learned, and this comes mostly from our um, rheumatology brethren, is that we give too much steroid. So once we give somebody 100 milligrams IV of methylprednisone, right, the genomic effects and the extra genomic effects and the surface receptors and the intracellular receptors, they are all saturated. So by the time you're getting to 250, everything's beginning to plateau here. So there's really, from a pharmacological standpoint, not much use of giving more than a 250 milligram pulse, but we are so ingrained in the 1 gram that every day I'm turning off the 1 gram pulse. We don't need that because the only thing you're buying after that is aseptic necrosis of the hip, which is, which happens more than you would think. And so, if you look at rheumatology literature, you would find that the dose dependent effects, right, go up very, very, very significantly on the high dose pulse regimens. And if you can use the lower dose pulse regimens, you decrease both the dose dependent effects as well as the time dependent effects of weight gain, diabetes, acne, and so on and so forth, and make it a little bit of a less miserable situation for the patient. So you will see these changes reflected in the way we are thinking about lupus nephritis today. So this is Bliss Ellen. I'm not going to spend a lot of time on the ins and outs of these trials, but just so that you have an idea, this trial was designed in 2010, so there are some things that are quirky about it. But anyways, everybody with active lupus nephritis, biopsy demonstrated seropositive lupus. They were started on a base immunosuppression, which is either MMF based or cyclophosphamide based immunosuppression. Everybody was on steroids. And then they were randomized to receive either belimumab, which is Benlysta in the United States. I don't know what this is marketed at as in Pakistan, or is it if it's available in Pakistan, or sham. So that's a straightforward randomized prospective double-blind controlled trial. And the endpoints were looking at your renal response parameters at week 104, which is a really good time, so that if somebody's got a failed therapy or flare or something, they would have demonstrated that. So belimumab was given intravenously. Now it's available subcutaneously, so it's easier for nephrologists to administer. But the belimumab was given on monthly infusions. Placebo, obviously, they got sham infusions. And so what you're looking for is GFR maintenance, proteinuria reduction, and the fact that they're not achieving this proteinuria reduction and GFR maintenance at the cost of very high steroids. So you had to taper the steroids by week 24. If this study was being designed today, we would taper the steroids by week 12, and it would be a mandatory taper to less than 5 milligrams. But that's how zeitgeist changes. So very big trial. There were about 448 patients in this trial. So that's a very good number for lupus nephritis trials. And so look at the black line. This is the primary efficacy renal response. And you can see that this is a slightly relaxed parameter. Proteinuria less than 700 milligrams per gram, GFR 60 mLs per minute, or no worse than 20 mLs per minute, 20% from the pre-flare value, and not a treatment failure. That means they're not needing more steroid pulses and all that. And so you can see that in the control arm, so these are patients who receive steroids, MMF, or cyclophosphamide, the response rate is about 30%. And this jumps to the mid 40s with belimumab. So you add an agent, you increase the likelihood that they would respond on the primary efficacy renal response criteria. They also use the more stringent criteria called the complete renal response. So this is proteinuria less than 500 milligram, GFR 90 mLs per minute, or no worse than 10 mLs, 10% from the pre-flare value, and not a treatment failure. And these patients went from 20% to 30%. So essentially, you're seeing an increase of about 10%. So I would like this graph to be here at 80%, but 40%, 45% is better than 20 to 30% is the point. So the next iteration, and these three trials that we're talking about, Nobility, Aurora, and Bliss LN, hit at the same time. Aurora and Bliss LN were phase 3 trials. Nobility was a phase 2 trial. And so voclosporin is kind of a modified cyclosporin. You don't need to use levels because the pharmacokinetics are very, very stable. calcineurin inhibitors also stabilize the podocytes. So we have been using calcineurin inhibitors in lupus for some time. I've been using tacrolimus in lupus nephritis for at least 10 years now. But this was a trial for voclosporin. Salient, very, very similar design to Bliss-LN. Again, you've got your patients with active seropositive lupus nephritis, biopsy demonstrated. Everybody got immunosuppression with MMF. And the interesting thing is the steroid dose here is really low. So essentially what you're looking at is a starting oral dose after the pulse, starting oral dose of 20 to 25 milligram per day, which is dropped very rapidly by about 4 months to 2.5 milligrams. So this is the modern take on how steroids should be used. So everybody got MMF, everybody got this attenuated steroid dose, and then the intervention arm got voclosporin, whereas the placebo arm got sham. And so again, in the interest of time, people who were in the control arm, which is MMF and steroids, 22.5% response rate, jumps almost to double at 40.8% with voclosporin. Now I'm going to wait on nobility, but so this started making its way into our guidelines. So now these are the EULAR 2023 guidelines, which are just being updated now. So the 2025 iteration is about to come out. And so everybody goes on hydroxychloroquine, that's a given. You want to put them on steroids, but the pulse now is 0.3 to 0.5 milligram per kilogram per day. This is the EULAR recommendation. Everybody goes on MMF, and then you can use other agents, but MMF is the primary skeleton of immunosuppression. You can use low-dose cyclophosphamide in certain considerations. For maintenance, you can use after that is an MMF. So the reason it's broken down over here is that if you're on MMF, as part of your initial treatment, you will continue maintenance with that. If you get the low-dose cyclophosphamide, you can then either go on ASA maintenance or MMF maintenance. In today's time, I don't use ASA maintenance unless I really have to, so I use MMF. And then you can consider other agents like belimumab and CNI. So now we are beginning to see these newer agents. So this is 2023. They're saying, okay, you can consider it, right? And I want you to see the metamorphosis of thought process, and this is happening almost in real time. So this is 2023. 2024 KDIGO lupus nephritis comes in, so I'm gonna not waste time with all that. We're looking at active class 3, class 4 lupus nephritis patients. Everybody gets a steroid pulse 0.25 to 0.5 grams per day. So see, we're kind of pushing the steroids down, and then you're going to put them on a lower dose oral regimen. And then they're giving you the options. You can use all of these. They consider them, you use whatever you feel like using. You can use a CNI. You can use belimumab in addition to mycophenolate, or cyclophosphamide. The reason this is different is because this recommendation of the belimumab comes from Bliss-LN. Bliss-LN allowed cyclophosphamide or MMF as the anchor, so it's been studied. The Aurora trial only allowed MMF as anchor immunosuppression. So if you want to use voclosporin, based on the trials and recommendations, you can combine it only with mycophenolate. Or you can still use, like Aves and Umar wanted to use in this patient, you can still use MPA or cyclophosphamide, but they didn't want to use cyclophosphamide. They wanted to use steroid and MPA. But understand, you do this, you're looking at a 20 to 30% response rate. You go this way or this way, you're looking at about a 40 to 45% response rate. This is 2024. Now they're saying, yes, you could probably do that. 2024 now. ACR lupus guidelines come about 3 or 4 months after the KDIGO guidelines come out. everybody who's got lupus goes on hydroxychloroquine. That's kind of a mantra that the rheumatologists follow, and it's benign enough to do, so I have no problem. But now look at the language. Now they are preferring triple therapy. So you want to prefer it. And we have walked away from the induction and maintenance jargon, because that tells us that if you're going to follow that scheme, then you're going to take something off. So now what we are saying is combination continuous therapy. So you put them on that therapy and you continue that therapy, because the idea is not only to get on top of the underlying disease process, the idea is to avoid flares. Why? Because each time there's a flare inside the kidney, you're going to have loss of kidney function. And so this is the metamorphosis of the thought process. So now let's go back to Umar and Aves and ask them, based on what we have just learned, would you treat Sandra differently now?
Yes, I would. Okay. So I would go on, steroids and also MMF. And this patient, because this patient doesn't have like a nephrotic range or close to that nephrotic range proteinuria, so I would, the third choice would be Belimumab or Benlysta. If this patient would have proteinuria like 4 gram almost, then I would go for a voclosporin.
And that's a fantastic way to parse it, and we'll kind of look at which agent to use in a little bit. But I agree with you. That's kind of what I would treat this patient with if she hit my clinic tomorrow. Omar, any thoughts on
Yeah,
at
I
your
think Sandra has good GFR, and so voclosporin is still part of the options on top of steroids and MMF. Uh, and sometimes, the prior authorization, availability, those things are also in consideration. Both drugs are difficult to get, but lately we have more success with voclosporin, so we are using that. That's still part of the triple therapy or the third drug.
How long do you use voclosporin for?
I don't know the answer to it, and that was my question.
I use 24 months.
Okay.
4 months. So you continue it for the 2 years, yeah. So
And actually,
yes.
nowadays it's much easier. For some reason, the company is very aggressive. I mean, I have not a single patient who has difficulty in getting that. I mean, even patient who had no insurance, even that.
Do you happen to know the cost of the system of one course of voclosporin for 6 months?
It's a lot. And actually, results are very good.
None of these agents are cheap. Voclosporin, the raw cost for a 6-month course is $140,000. Benlysta is about $80,000. So these are all expensive drugs. But yes, I would use triple therapy, combination therapy on this patient in light of what we are reading here. And in somebody with class 3 or class 4 lupus, without very high proteinuria levels, and especially if there's no class 5 component, I prefer Benlysta. And the reason I prefer Benlysta or Belimumab in those cases is because of the very salutary effect it has on flare rates. And we can in another session go into the details of why one is better for flares than the others. But the flare rates are very important, relapses, flares, reduction, and then ongoing maintenance, because we'll talk about how to take off immunosuppression in a little bit. And so that really gets into that mix. But voclosporin is a perfectly logical choice. You can use that for your triple therapy as well.
Will,
Now,
would you like to answer some of the questions in the chat? This is,
sure.
Should we address something now, or you have, or finish what you are doing it?
Let's do this. Let me finish the story of B cell depletion. Then we will pause, take questions, and then see how much time we have to go into the next phase of the talk, right?
Oh.
All right. So, I have kind of avoided talking about the B cell depletion thing here. Now, lupus is a B cell mediated disease. So when rituximab came out, there was euphoria that, oh, this is it. Once we give somebody rituximab, people will get better. So there was a trial called Lunar that was done in the mid 2010s. And unfortunately, the trial did not show any significant difference. But then they went back and did a post hoc analysis. And what they found was that the patients who actually depleted their B cells, so the CD19 counts dropped significantly, which is in these gray bars, had much higher level of response to the rituximab than the patients who did not. And so Liz Lightstone from the UK has been trying to do steroid avoidance and rituximab for a long period of time. She did this trial called Rituxlip again in the early 2010s. The trial actually was halted because of difficulties with recruitment, but it did send a signal that people getting rituximab were maybe having some form of a response. But then this was studied in more detail in a trial called Nobility. So I said that there were 3 trials that came out almost back to back in 2020 or 2021. One of them was Bliss LN, one of them was Aurora, and the third was Nobility. So Nobility is using obinutuzumab. And so this was a phase 2 trial, which was then confirmed in a phase 3 trial, which was just published in February, I think, this year in the New England Journal of Medicine called Regency, which shows that depletion of B cells, effective depletion of B cells, actually drive meaningful responses in patients with lupus nephritis. So very quickly, we will see obinutuzumab climb up. It will be a same dance we'll have to dance with approvals and availability, but this will start replacing rituximab in many different spheres of glomerulonephritis treatment, in membranous as well as in lupus nephritis and perhaps in ANCA-associated vasculitis. Now, there's been a lot of talk about depleting B cells using CAR T cell therapy. I'm not going to go into detail. Suffice it to say that this is still experimental, exponentially expensive, and fraught with its own problems like cytokine release syndromes, ICANS, and so on and so forth. So this remains something which is experimental at this time. This remains a subject of intense research, but it is not ready for prime time. However, what may actually sidestep bidirectional antibodies, CAR T cells, is bidirectional antibodies. So these are antibodies that have got different specificities on the 2 arms of their variable regions. And so on the one side, it will find a T cell. On the other side, it will find a target of interest. So in this particular case, you're looking at the antibody is swinging around a CD3 cell, and it is bringing it into close proximity to a CD20 B cell. And so that leads to profound B cell depletion. And this may actually be much less toxic and cheap compared to CAR T cell therapy. So my feeling is that this is going to sidestep what CAR T cells are doing, and we'll probably use bidirectional antibodies, not just in lupus, but many other places where we are using depletion therapy. So this is, in a nutshell, what I've spoken about in the past hour or so. Our traditional paradigm of treating this disease is we start with steroids and mycophenolic acid preparation. Sometimes we use cyclophosphamide. 60% don't respond. They have ongoing activity. They have flares. They get multiple bouts of steroids in the middle because they are not responding. And then eventually we say, okay, we need to do something. And then, months later and perhaps a biopsy later, we say, okay, we need to put something else on. So we are now thinking about inverting this paradigm, invert the pyramid. We start with multiple agents. We individualize the regimen based on what we think would be the best combination for a particular patient. And then once we've got the patient into remission and we are sure that we've got control over the disease, we then start peeling off therapy. So that's the first part of what I wanted to talk about today. So we have started Sandra on combination therapy. We'll talk about now what in a second, but Omar, if you want to go over the questions, that's fine too.
Yeah, thank you. I think there were initial some of the chat and direct feedback about the questions you ask us. I think we got some responses if the patient will get pulse or not pulse. And then I think there is a comment, there is a theme of how aggressive the class 3 is. Is this less aggressive, and how aggressive you need to be in terms of the treatment because of the concern of side effect? Dr. Chaudhary asked about young patients have side effects from high dose steroids, and then I think there was a follow-up question that is this really an emergency or a more subacute presentation? Is time really nephron in that particular patient? And then is waiting okay on the steroids? So some of the questions around that, and if I think really summarize that, this one discussion is really the how aggressive or how proliferative is this class 3, and then what should be our response, because I think one question was like, what's the risk of you achieve this 20 to 30% remission in 1 year, what was the risk data? And I think one experience was shared that again, side effect profile. So if you can touch base on that, and then I'll go to the second theme.
So like I said, that when you're including these patients in these trials, you're lumping all active lupus nephritis together. So then the study becomes underpowered to answer on one particular facet. But class 3, so there's a couple of things about this classification, and this goes on to the need for having a full conversation about pathology of lupus nephritis. But if you do 2 cores of a biopsy, 1 core, and you get another core, and send them to 2 different pathologists, there's a 50% chance, so 1 in 2 chance, that one of them will read it as a 3 and the other one will read it as a 4. Not that they are dumb, but that's what they get. It may be focal disease, right? So in 1 core you'll find 3, in another core you'll find 4. When you look at pooled outcome data, your 10-year end stage renal disease risk with membranous is 10 to 20%, with 3 or 4s, or 3 and 4 with 5 is 20 to 30%. That's a very high risk of disease. And I told you that in about 70% of cases, the biopsy changes. So if you were a 4, you may be a 3 on the rebiopsy. If you're a 3, you may be a 4 and with 5 on the biopsy, on the rebiopsy. So these things we kind of try to pigeonhole very, very simplistically because of how we have thought about this disease. And so the way I look at this disease is I have 3 boxes. I have 1 and 2, which means not much going on, 3 and 4, which means hypercellular inflammatory disease, and 5, which means a membranous pattern of disease. And I approach all 3 boxes slightly differently, and my choice of agents for the 3 boxes is different. Now, class 5 is the red-haired stepchild of lupus nephritis, and we just throw it into lupus nephritis trials. Ideally, one would like to have a completely different trial on class 5 because I think it's a completely different disease from a pathogenetic standpoint, and it responds very differently. And so when we, as we progress in the talk, I'll try to tease some of that nuance out as well. I hope that captures all of the questions.
Yes, I think you covered this well, and then I think there are two more practical questions, and if I can ask you stepwise. One is if there is strong suspicion of lupus but biopsy is difficult to perform because patient is sick or in ICU or some other. So should you wait to do biopsy or consider steroids, oral versus pulse? That is one question. The other question, if I can also add to it, that you have a patient when creatinine is 156 micromole. I was just trying to do the conversation. What would that be on?
1.6, 1.7 milligrams per
Okay,
deciliter.
1.617. So, but the biopsy shows class 4 progressing to chronic changes, moderate to severe tubular atrophy. Is this patient a candidate for immunosuppression or not?
Yes. And the previous question, steroids, yes. If you can't do a biopsy and you're pretty certain that you're dealing with an active lupus nephritis, I mean, spin the urine, right? And if you find red cell casts and all that, and you're worried that this is an acute glomerulonephritic process and you've got active lupus nephritis with serologies and yada yada, I would treat with steroids if you can't biopsy due to whatever technical reason. Okay.
All right. Yeah, I think we have a few more questions which we can take later. I think if you need to go.
So now you've put Sandra on therapy. When would you say that she's got refractory lupus? How would you say that she's got refractory lupus? Or how would you say that she's responded? When would you say that she's responded? So, you've started her today on triple therapy. So, Umar, I'll throw it to you. What's your practice?
So I think the duration, we just started that discussion before. So 2 years versus 3 years. So one would be the duration. The other is
I'm asking a slightly different question. So Sandra has got, let's make it a little bit more interesting. Sandra has got 3 grams of protein in the urine. Her GFR is 80 mLs per minute, and you've started her on steroids, MMF, and Benlysta, and it is August. So now follow me through. Would you wait 2 years to determine if she's responded or not?
so
I would wait for 3 months or 6 months. I mean, it depends on that how much proteinuria has decreased, either 25% or 50%. I mean, that would be my idea of any responding or not. Yeah, with just 3 months is at least I would give you some idea that whether she would respond or not, or 6 months is a good time to see whether that she is responding or not.
Fantastic. Yeah, that's pretty much on the nose. So essentially, so what you're trying to do, the way this disease is, even with full-blown treatment, you don't get it to shut off in a day or so, right? So you've given the steroid pulse, you're starting the anti-inflammatory therapy. Some of the things are getting better. Like I said, that the crescents get better, some of the inflammatory response get better, but the other inflammation takes time because it has to immunologically alter the disease milieu and then on ground has to take care of inflammation. And so it takes about 3 to 6 months for the disease to respond. But at about 3 months, what you should be seeing is a 25% drop in proteinuria. So let's suppose you start Sandra on pulse and you do everything, and then a few weeks later you've got her on an ACE. A few weeks later, the proteinuria is 3 grams, right? Like we discussed hypothetically. So it should have gone down to 2.5 or so, and then you see continuous improvement and you see the GFR either go up a little bit or stabilize, and Sandra's clinical manifestations getting better, then you say, yeah, the likelihood that she would respond at 6 months is high. If she doesn't respond by at least 25%, then you know you're in trouble. Why this is important is that saves time for you. Because if you're at 3 months and her proteinuria is 5 grams now and her GFR is dropping, you know things are not better and you have to do something differently. So at 3 months or 6 months, somewhere in that window, you will have to classify as that lupus being responsive to underlying to your first line therapy, or refractory to it. So when you're looking at refractory lupus, and lupus that has not responded to your therapy, you have to answer the question, is it really refractory? Which means that has, any immunological response been achieved or no? Have we given the regimen a chance? Have they been taking the medicine? Has the regimen been good? I see all the time people are placed on MMF 500 BID. You have to get them to 2 to 3 grams for the MMF to be adequate in lupus nephritis, or sometimes they don't take their medicine because they are non-compliant. And then we have to figure out when to rebiopsy. And the answer increasingly is whenever you're not sure, you have to rebiopsy. But one of the tricks to demonstrate compliance is to check a hydroxychloroquine level. And so hydroxychloroquine has a very long half-life, so you can't drop the level if you've missed it for a few days, and you can't jack the level back up if you take it a couple of times before your appointment, because professional patients sometimes will do that because they say, oh, the doc's gonna be unhappy with me, so they'll take their medicine right before the test. But hydroxychloroquine you can't change, and there's a very clear cutoff where, if your levels are above 1,000 nanogram per liter. So in this case, it would be above 1 milligram per liter on this schematic. Your risk of flare and remission is really low compared to if your levels are lower. So hydroxychloroquine is a tool. You can do pill counts, and there's smart pills and all that, but we're not gonna go too much into that detail. Now, if you feel that they are being non-compliant, you can put them on IV cyclophosphamide and IV Benlysta. That way, you can actually check the levels. You can put them instead of voclosporin on Envarsus or Prograf, and you can check levels. So there are ways to look at adherence. But once you've demonstrated that I've let enough time pass, at least 3 to 4 months, and I have made sure that they're taking their medicine, if you're still in that zone where you're getting a suboptimal response, then especially if they are worsening, you label them as true refractory disease. If they get better, you say, okay, I'm going to continue with the management. But this decision needs to be made. We need to get all of this squared away in the 3 to 6 month window, sooner if they're losing GFR or if the proteinuria is really getting worse. So the moral of this is don't wait forever on this, hoping that you put them on MMF and steroids and now, God will do what they will. The important thing is to stay on top of this, because that's where you're losing your kidney. So the time is nephron part is here, where you're not getting on top of the disease process. You're letting that simmering inflammation inside the kidney. So the question that was asked, that the creatinine is now 1.6 or 150 micromoles, and there's moderate interstitial fibrosis, that's what is going to happen to Sandra. And then we will start saying, oh, should we be doing anything? And the answer in that case is yes, we need to get on top of whatever inflammation is left so that Sandra doesn't end up on dialysis. Because once Sandra gets to a creatinine of 2 or 190 micromoles, then she has doubled her serum creatinine, which is a very reliable indicator that this patient is going to progress to end-stage kidney disease. So once you've got true refractory disease, you have to answer the question, why do we think they are refractory, right? Now, refractory in this situation means they got proteinuria. Proteinuria can be because they've got active disease or they've got scar in the kidney. So many a times in these cases, you need to do a biopsy. Once you've done a biopsy, you can then do several things. You can change to an alternate base. If they were not on triple therapy, put them on triple therapy. If they start responding, great. If not, you have to B-cell deplete them. And the B-cell depletion used to be with rituximab. Increasingly, it'll be with obinutuzumab. And then there are other therapies like we talked about, bidirectional antibodies and CAR-Ts, which come lower down the queue. They are more of a research nature right now. So in our particular situation, stiffening up immunosuppression and B cell depleting them with antibody therapy is probably our best bet to get on top of this. And OB is now finding its way up in the food chain of early intervention. And so in the British Rheumatological Society recommendations that are coming out for lupus nephritis, they have not come out. They're going to be coming out in a few months, I think. Or they may have come out, but either that or will come out in a few months. They are actually recommending OB as one of the early options. You B cell deplete, and that's your third agent, along with an MMF and steroid anchor. So I'm going to stop here. Omar, any questions? Because then we'll go on for a few minutes talking about how to get off of immunosuppression. So any questions that
You
you
find
think?
just a quick question for
Yeah,
compliance. Do you check MMF level ever or not really?
that's a good question. MMF levels, unfortunately, do not reflect the area under the curve because of the enterohepatic circulation that MMF has. But I use them mostly to check toxicity. So if somebody comes in with a wiped out bone marrow, I check an MMF level, and if it's 5, I'm like, yeah, that's too much MMF, and that helps me. But the low part sometimes doesn't correlate. Secondly, it can move with 1 or 2 doses. It's a shorter acting drug. So when you're looking at long-term compliance, hydroxychloroquine is a better bet.
So I think
So
one
whenever
question.
you're looking at trough levels, it's not just the level indicates the area under the curve, right? So it has to confer that information that this is the time frame the drug was pharmacodynamically active in the body. So if the trough is not giving us that information than the trough itself. So in transplantation, there was a lot of commotion about MMF levels 15, 20 years ago. We don't do them anymore. But the only time I do that is for toxicity. I check it for compliance sometimes. If it's completely zero, you have your answer. But you can actually drop the MMF level pretty low after 2 doses. So if somebody comes in and say, hey, your MMF level, so yeah, doc, I ran out of it, but I was taking it till Friday and today is only Wednesday. But you check a hydroxychloroquine level and it's in the toilet. No, you weren't taking hydroxychloroquine for weeks. So likely you weren't taking your MMF for weeks as well.
So I have a question on the duration of the total duration of the therapy. So say Sandra responded at 6 months, things were in that response direction. Like, there you see an improvement in proteinuria, you see improvement in the markers. So at 6 months, what do you do? At year number 2 and 3, what do you do? I think I just want to understand the paradigm, as previously we understood this induction of remission and maintenance therapy. So just your feedback as, once you receive a good response, what do you do next?
So that is a perfect segue into how to get off the tiger, right? So let's suppose Sandra, 3 months, we had a heart attack that, her proteinuria is not getting better, and we did this and that and the other, we adjusted doses. And by 6 months, her proteinuria is now 300 milligram per gram, GFR is well controlled. So she's had a complete renal remission, which is what we want to see. Now we've already reduced her prednisone to 5 milligrams per day, right? And so now what are we going to do for maintenance, right? So patients who are on combination therapy, right? So in this particular case, let's suppose we had put Sandra on MMF, prednisone, and belimumab. They will continue with the immunosuppression, and the immunosuppression needs to be continued for 2 to 3 years. So there's a very long maintenance phase or continued treatment phase. But if you started them on triple therapy, they need to be on triple therapy. If MP is not tolerated, there are other options. But going with 80%, 90% of the patients who are going to be on triple therapy, this is what we want to do. Now, the reason we want prolonged therapy is to cut off flares. cut off the disease activity completely. And then eventually, we hope that the regulatory arm of the immune system will control the autoimmune response and we won't see the risk of flares. Even then, after 2 or 3 years, when we stop, some patients flare. And so, my practice is that after 2 to 3 years, when they've been completely quiet, no problem, I start taking the MMF off. I commit blasphemy in many cases and take the prednisone off sooner. So in Sandra's case, if she was completely controlled at 6 to 12 months, or 12 to 18 months, so 6 months of complete remission, I might take her off the prednisone, but not everybody agrees with that. And the rheumatologists certainly do not agree with that. They like to keep patients on prednisone. So there's this style thing and personal preference. So this is my personal um, um, preference. The recommendations are reduce the prednisone to less than 5 milligrams. And then the rheumatologist sometimes will do a very painfully slow 5 to 4, 4 to 3 type reduction. That's their practice. And then once I've gotten rid of the steroids, once I've gotten rid of the MPA, then after a year or so, I take the belimumab off. But again, the rheumatologists say, why? You keep them on the belimumab because they're probably going to have a relapse after that. So there's this difference in approach between rheumatology and nephrology. But from a pure continued immunosuppression standpoint, you want to stay on immunosuppression for 2 to 3 years. Does that answer your question?
Yeah, thank you. I think that was good.
I think that was my last slide, and I'll welcome any questions if there were any more questions to answer.
So let me, I know that in chat there are some questions, maybe Dr. Agha, if you want to go through it, but let me ask my colleagues from Pakistan as how are they managing with with their preferred agent if they have patient like Sandra we discussed. Dr. Mateen, I think you unmuted.
Dr. Umar, actually, we don't have any availability of this valcosporin or belimumab. So we oftenly treat this. If I will be treating physician of the Sandra, that I will pulse with solomedrol, and then I will continue with the induction therapy of oral steroids plus mycophenolate. The only available in Pakistan is mycophenolate. Valcosporin and belimumab is not available.
How about cyclophosphamide? I mean, old is gold.
Yes, the cyclophosphamide, because we have most of the patient of the females unmarried, there is a question about this toxicity of the cyclophosphamide regarding of future aspects of marriage or something like this.
Yeah, I mean, young woman, you don't want cyclophosphamide.
And I think there is a comment from Dr. Tarif about triple therapy with half-dose steroids, tacrolimus, and then plus PSI plus MMF. What would be PSI? I'm sorry, I missed that part. Anybody can decipher that PSI for me?
Yes. Maybe I mentioned something, but the connection is a little unstable. I hope.
Okay, so you mentioned this triple therapy with half-dose steroids, tacrolimus plus PSI plus MMF.
Prednisolone.
Okay, prednisolone. Okay, so
PSL, I think prednisolone.
PSL. Okay, that makes sense now.
But there's a comment which I think we need to highlight. There's a question that Dr. Chaudhary is asking that any data on conservative management with SGLT2 and ACE in patients with good GFR, even proliferative class 3 before immunosuppressants in patients like Sandra. So let me just kind of make this point as emphatically as I can. There is immunological management of disease, and then there is protection. Protection is of secondary importance. It's not that it's not important, but it's of secondary concern. The most important thing is avoiding immunological injury. So it is not an either or proposition, it's an and proposition. You treat the immunological injury and the glomerular inflammation by using steroids and MMF and belimumab or voclosporin or obinutuzumab, whatever we're doing. That is one magisterium of therapy, which is important. This is direct disease modifying therapy, if you will. Then there is protective therapy. ACE inhibitors, SGLT2s, MRAs, all of those come, GLP-1s now, all of them drop into the protective therapy component. They're not doing anything to the disease activity. They're like protecting the kidney from whatever injury is happening because of disease injury. And this is the same paradigm which needs to be preached in other GNs like IgA nephropathy, where people go with this Chinese menu approach that, I put them on Filspari, so I'm good. No, there's protective therapy and there's disease modifying therapy. So I think this is a good question to highlight the conceptual basis of what you're doing and why. Immunosuppression is to modify the disease itself, and then chronic kidney disease management and nephroprotection is to ameliorate the injury that is happening because of the index disease.
I have a question, if I can.
Please go ahead.
Thank you, Dr. Irfan. Actually, my name might be Syed Khalid, but I'm Arsalan.
I can identify your voice, Arsalan. Go ahead, brother.
Okay, just one common scenario for Pakistan. The most frustrating for me for lupus, middle-aged females, 30s to 40s, chronic disease, been on medications. I'm the fourth or the fifth physician they are consulting for a second or third or fourth opinion. Proteinuria between 2 to 4 grams. Been on MMF, bread, plus minus. We use TAC over here because obviously we don't have voclosporin and all that. They've been on these immunosuppression for 3 to 4 years. Their proteinuria is still persistent between 2 to 4 grams, as I mentioned, and they're frustrated. They want to come off the immunosuppression. The biopsy about a year ago showed about like 20%, 30% IFTA and, mild proliferative disease. How to go about it? I mean, like, specifically in relevance to Pakistan, we don't have any options. Now, the question I would say, do you think I could offer them a B-cell therapy? I mean, we have a bintuzumab, we have other things. I mean, and try to see if they could be weaned off. We could just dip off the immunosuppression and see what they do. Should a rebiopsy? What should be your stance in this case?
Yeah, so the toughest patients to deal with are these middle molecules,
Smoldering disease,
as I call them, right? So you respond, we're all happy. You don't respond, we know what to do. It's these middle of the road guys where, let's take your example, somebody who started with 4 grams of protein, and then they've had some form of therapy, maybe not, and now they've got a gram and a half of protein, but it's still there, right?
Mm-hmm.
Now, in my practice, I used to take a lot of pride in I can really tell which one's active and which one's not. I wish there were good blood and urine markers to tell us, what's what. Is this continued activity or not? But I have learned to be very humble because I've been wrong as much as I've been right in predicting what I would find on a biopsy. So the first thing to do in cases like this is to biopsy them. And if you find on the biopsy that there's still active disease, then you have your answer. You need to treat them. If on the biopsy you find you've just got inactive disease and chronic change, adaptive FSGS and what have you, then you have your answer also. That in this particular case, what you need to do is to maximize your CKD therapies. And so the biopsy is still the best, I would say the only arbiter which would tell you what to do. We are getting close to having proteomic panels, as well as many other biomarkers in blood and urine, tweak various interleukin profiles, CD163, et cetera, et cetera. So people are looking at proteomic panels. Johns Hopkins people are doing a lot of work on that. And then people are looking at individual biomarker panels to answer this very question so that we can reduce the need for rebiopsy. But in this particular situation, Arsalan, if you're trying to deal with this patient who's very difficult, it's hard to say whether she's got ongoing damage or not because the wages of guessing wrong. So if you think that we've given her enough, she didn't want to take it, let's put her on an ACE inhibitor and SGLT2 inhibitors and roll the dice. If you're wrong, she'll end up on dialysis in a few years. And she's still young. She's in her 40s, you said. On the other hand, if she's got completely inactive disease, right? And she's got scar and adaptive FSGS, and that's what's driving the 1.5 grams of protein, then giving her more immunosuppression is not going to do squat for that. It will, however, expose her to the expense and risk of added immunosuppression. So I think the approach to this question is through the back. You do a biopsy, figure out how much chronic change, how much active disease, and if there is active disease, then you figure out what is the best way to treat this patient. If they're non-compliant, should I give them cyclophosphamide? Should I give them OB, one and done? Or should I give them rituximab and hope that they would respond?
I guess, I'm sorry, I just to pinpoint a particular question. My thing was exactly what you said at the end was that, could that long-standing, if let's suppose I do a biopsy and there's is still some activity going on, can I replace the Obin or the Ritux with, she would say, oh, I'm just done. I just give me an OB or whatever I would say with Ritux rather than taking this expensive medicines and everyday compliance issues and all that. Could I consider that as an option in which I would, be really frustrated with 3 to 4 years of disease activity and getting with something that might just, decrease the burden of the medications and all that?
In patients like this, I do actually switch the treatment. And so I would use either urolupus-based cyclophosphamide if this patient came to me here, or I would deplete them with rituximab or OB. And then understand that you will have to put them on maintenance again. It's not one and done. They will still need to be on maintenance, but those are lower levels and hopefully they'll take their medicines.
Thank you very much.
So on the same token, on the rebiopsy, I think we discussed the rebiopsy of this middle of the lane patients. Is there any need or indication to do rebiopsy if somebody is responding really well? You have completed before you do the immunosuppression withdrawal. I think this is how the question was, to see if there is any histological activity index. Do you do rebiopsy before stopping the immunosuppression when they are actually responding well?
Yeah, that's a phenomenal question. So here's what my practice is, right? Because this is all opinion based now. So my practice is if they respond completely, right? So if Sandra came out and her proteinuria went to below 300, 400 milligram per gram, there was no blood in the urine, GFR was maintained, she's feeling great, she's not had any flares. 6 months later, she's looking great. 1 year later, she's looking great. And I'm just coasting. I would not do another biopsy on her. Mutatis mutandis, Sandra comes in and she's worse, right? I would probably biopsy her at 3 months or 4 months so that, I can figure out what the hell's going on. Where did I go wrong? What do I need to do? Now, in the middle of the road pack, right? If she's getting better, but slowly, I might give her a little bit more time. So at 3 months, she's had a 20%, 25% reduction. I'm happy with that. But I might give her another month, and if she's continuing to get better, I'll give her more time, especially if she had a membranous component. Membranous behaves differently from 3 and 4. Membranous takes a much longer period of time to resolve. So it is not unusual. If I have a pure class 5 and I've put them on therapy, I might wait 12 months, 18 months before I really say, I need to do something about this. As long as their GFR is maintained, they don't have a lot of hematuria, they just got the protein, it is slowly getting better, I would wait. But it's a 3 and a 4, and they still have 2 grams of protein, and it's 6 months down the line and they're not getting better, I'd biopsy them.
Another timeline question from Dr. Muhammad Ali is, if I rephrase this, that is this necessary? So Sandra, at 1.5 year, things are doing great. Is this really necessary to continue for 36 months of treatment if patient is in remission?
Yeah. So you have to understand why you're doing this, right? So why is it that you're able to take the immunosuppression off at 3 years and not at 15 months or 12 months or 6 months? So theoretically, if you really reduce this argument to simplicity, then you should say, okay, Sandra has had a response. At 6 months, you're saying she's looking good, right? Then you are continuing immunosuppression for an additional year. I would reverse the question, why? And so you're doing it because you understand that there is immunosuppression required for a particular duration of time after a complete response has received. And the idea here is you want to reduce intrarenal activity, which is quiet. You want to reduce flares, and you want to cut off the possibility of relapse. And so the safe target for that is not 1 year, which you're conceding in your question. It is 2 to 3 years, depending on the clinical scenario, because that is about the time where we see intrarenal activity, we see some damage, and there's some very elegant studies which looked at biopsies at 9 months and 4 years. And you can actually see the metamorphosis of the kidney damage and the types of it that happens on therapy. So it is not like you win the battle when the proteinuria drops. Those are just markers. You win the battle when the kidney stays quiet without flares and activities for 3 years, 4 years, and then you're able to tiptoe away from immunosuppression, and you're able to guarantee them a good dialysis-free survival.
Thank you. I think we covered most of the questions, if not all, or the themes. So I think there's one last question. Maybe we can take it and then we can conclude the session. Or what kind of side effects are you seeing in these patients with triple therapy, and has that modified your treatment action plans?
Yeah. So I mean, again, I'm informed by results of Nobility, Bliss LN, and voclosporin. So you've got the experiment right there, right? And so if you look at the control arms and then the intervention arms of these 3 trials, you will find that there's no difference in treatment emergent adverse events, serious adverse events, fatalities, yada, 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 in the treatment arm versus the control arms. Now, Regency is a little bit of an outlier. Now, Regency was recruiting at the peak of the COVID epidemic. And so now you're B-cell depleting these people right as we are getting into COVID. And so that became a little bit of a problem. So there were more treatment emergent adverse events in Regency compared to the control arm, but that is entirely understandable. And the entire difference is COVID infections. You take the COVID infections out, there's no difference. So when you look at the additional cost in terms of side effects, it doesn't look like you're doing too much. There was a trial on the Aurora patients. They did interval kidney biopsies to see if there was any significant calcineurin inhibitor toxicity driven by voclosporin use, and the answer was we didn't see much.
Yeah, thank you very much. Maybe I think this is almost 3 o'clock here, and I'm sure quite late in Pakistan as well. So we should conclude the session in my mind. I will ask Dr. Masood if you want to say something, then Dr. Agha if you want to conclude it.
No, I don't have to add anything. It was a great discussion. I learned a few things, and maybe one I can pinpoint that there is not much difference between class 3 and class 4 initial treatment, which is a little bit different from what I was practicing. So I took home some, new recommendations.
always new learning points through these sessions. And if I go back to previous session and this session, I think a few years ago we had a Lupus 1 and Lupus 2 session. Science has changed. And thank you for kind of critically analyzing that evidence and shaping the direction and approach that we take towards these patients. So really, I think what you do, if our learning and education is improved, the benefit will go back to the patients we treat. Thank you very much. And Dr. Ala, please, house is yours for final remarks.
I think I've already spoken too much. People are probably sick of my voice now, but thank you for everybody's attention. And yeah, I was looking back. The last time we did that was 2020, so it was 5 years ago. It doesn't look like it's been 5 years, but it has been half a decade. And you're exactly right. The science has changed, and there's new exciting things on the fore. And I think in a couple of years when we'll have this talk, hopefully not a couple of years, maybe next year, we will start looking at some biomarkers being tried. In a few years, we'll have biomarkers at bedside where, some of these questions that are being asked, because the answer right now is like Arsalan's question, the answer is biopsy, but maybe we are able to use biomarkers that would cut down the need for rebiopsying and also allow us to see if our immunosuppression is effective, or are we condemning our patients to what is known as silent lupus, where we think they're in remission, but the kidney is being chewed out slowly.
Thank you, everyone. And, have a great night and have a great rest of the day. Bye.
Goodbye, everybody.
Thank you.
Bye.
Thank you.